Hello, everyone. My name is Glenn Pierce. I'm the Vice President for Medical for the World Federation of Hemophilia, and I'd like to welcome you to our third webinar in this COVID period. This webinar is on dental care for people with bleeding disorders during COVID-19. What has changed? Next slide, please. Our speakers include Dr. Alison Dougall, Dr. Zikra Alkhayal, and Dr. Elvira Correa. Next slide. Our agenda is going to include the following topics: impact of COVID-19 on dentistry, where all of our speakers are going to contribute; how patients cope, self-management of dental complications during confinement; risk assessment of procedures; and finally, prevention. Why was it important pre-COVID-19, now and for the future? Next. We've done two other webinars and have published a COVID section on the WFH website, which I would encourage you to go to. We've included practical recommendations, specific risks of COVID-19 to the bleeding disorders community, information for humanitarian aid countries where it was difficult for a period of time to get shipments into the countries. Some of that has eased, but there still are periodic problems due to the lack of air transport. And then a variety of company statements from the pharmaceutical industry, specifically regarding their products with respect to COVID-19. Next. If you want to ask a question, you can use the Q&A button on the bottom of your screen. If you miss the Q&A button, the chat button will also capture questions, and either of those will work. I'll be monitoring for both of those. And then we'll take those toward the end. We are recording this webinar, and so the webinar will be on our e-learning platform together with the other COVID webinars, as well as you know, many other learning materials. And so I would encourage you to go there. Next. Basic questions on COVID-19. Nothing really has changed with respect to the bleeding disorders community since the last webinars that we've done. Are people with hemophilia or other bleeding disorders at increased risk of having COVID-19? No, not at all. There are risk factors that have been well publicized, and that will increase your chances of having a severe infection. Can COVID-19 be transmitted through plasma products? We're now several months into this pandemic, and the answer is no. We aren't finding any evidence of transmission through plasma products. And so that's important to closely monitor, but that is looking like that will not be a problem, as it wasn't for other coronavirus infections. And then finally, does COVID-19 treatment protocol require special care for bleeding disorders? And in this case, the answer is yes. We are learning more and more about the clotting problems that are occurring in the infection, especially in the severe infection, which actually can be responsible for death. And so individuals with hemophilia will require special management if they have COVID-19 and are in the hospital with a serious infection. So that is important to make sure that contact is maintained with the Hemophilia Treatment Center in that situation. Next slide. And finally, I'd like to remind you about the virtual summit, the WFH Virtual Summit that is coming up in actually about a week and a half. June 14th to June 19th, we'll have a number of simultaneous sessions on a variety of topics of interest to the bleeding disorders community, and there will be a COVID-19 specific session on the last day of the conference, Friday, June 19th, 9 to 10 Eastern Daylight Time. Next slide. So our first talk will be from Dr. Alison Dougall, and she will lead off with the impact of COVID-19 on dentistry. Alison?
Hello, and next slide. I'm really delighted to be here. I'm a dentist working in Ireland. I've been working with people with bleeding disorders for about the last 15 years. I'm the former chair of the WFH Dental Committee, the MASAG of the EHC and the Irish Hemophilia Council. So I've been providing dental care during the pandemic, the front line, both via face-to-face care and teledentistry. So where are we with dentistry? Well, we've always been at risk in dentistry from all the infections. We've also been at risk of passing on infections. So this has been an incredibly large focus for dentistry. For really since HIV in the 80s, we transformed the way we provided dentistry. We have to have dental nursing assistants who are experts in cross-contamination and disinfection. We have to wear a tremendous amount of PPE, but in the past, it's always been about bloodborne infections or splatter from saliva. And next slide. The thing that's changed with COVID is that we can't carry out social distancing in dentistry. By definition, a mask has to come off in a patient to be able to provide dentistry. Next slide. And so social distancing is impossible. Next slide, please. And as you can see, even just coughing or breathing heavily produces this aerosol. And what we've learned very quickly is that the COVID virus is in very high concentrations in the nose, in the throat, but also in the saliva. So this ability to throw aerosols into the air has really made dentistry a high risk procedure at this point, both for operators and for patients. Next slide. So what this meant was early on, while we were still collecting information from China, the first thing that happened was that people had to be providing emergency care in really high levels of PPE. You can see here full body suits, masks with valves, waterproof gowns, and full visors. Next slide, please. And also, really importantly, after dentistry was carried out, because of throwing these particles into the air that can be there for up to an hour, some would say 3 hours, there's this big gap between being able to provide care in the normal way we would for dentistry, patient after patient, while a deep cleaning and sanitization of the area needs to take place. Next slide. So this really had the effect very quickly of either governments closing down, forcing closed dentistry, or dentists stopping overnight to be able to provide safe care while all that information was being gathered. And this had a huge impact on the business of dentistry, but also on patients' access to care, where all of a sudden patients were only able to access emergency care. And I don't think that was ever really explained very well to patients why that would be. And more to the point that emergency care, when it was available, only was sort of limited to things like extractions that don't throw up the aerosols into the air. And that's a big, big kind of impact for somebody with a bleeding disorder. Next slide. So if we look about where we are in Europe, in the next section, we're going to talk about where we are in each area of the world. I'm British, you can probably tell from my accent. Next slide. I'm not living in the UK, probably thankfully at the moment, because it's really, struggling to control, or it has been, the virus. But if you have a look in Europe, China and South Korea, Hong Kong, Europe was where we learned a lot of lessons, and especially we did in dentistry. You can see here every country is involved at the moment. The highest areas with number of cases is Russia, the UK, Spain, Italy, Germany. Next slide. But what we learned from dentistry from Spain and Italy was that dentists died. Large numbers, I mean significant numbers of dental staff died. But what we also learnt was that toothache is excruciating and that patients could not go without dental care for very long. And even those most medically complex would break quarantine to need to go and have urgent dental care. So I think that was really something that we realized we had to actually come back and provide care, but that we had to be very careful in the way that we did that. Next slide. So where are we now? We have been a long time providing care, emergency only care, via teledentistry, but you can only medically manage some things. But we are just opening practices back very slowly at the moment, and that's according to very strict guidelines. I'll talk a little bit about that later. But so some of you may now be starting to get access to dental care, but it will be a little bit different at the moment. Next slide. Next slide, please. Thank you. The first thing is that, as I say, there's a huge amount of additional PPE. We've always worn masks, gloves, but now we've got to have better masks. We've got to have full waterproof gowns, for example. But the new normal is that at the moment still, sometimes at the moment, there is unavailability of the teams. In Ireland, for example, a lot of the hospital dentists who maybe people with haemophilia would have seen have been repurposed. They're doing the swabbing and tracing. We're able to swab throats and noses, so a lot of us have been sent there. Or they've been sent to emergency centres, so they're not so available. So what it means is somebody with a bleeding disorder who relies on trust and knowing their practitioners may not be able to see the person they usually see. Those procedures that form an aerosol, every time we lift our handpieces, we actually you know, all the things that blow water and air, all the things you hate, those are the things that blow an aerosol into the atmosphere. So those sort of things, fillings, even root canals sometimes, and most certainly things like the ultrasonic cleaning, which is so important usually to maintain good health. Those are the sort of things that throw the aerosols up and that are limited at the moment. There's also lesser availability of appointments. So although everybody will be wanting to get back to the dentist because they've got issues or they're worried about their health, there's lesser availability because less dentists are opening at the moment. But also these big gaps between appointments mean that whereas we would often have been able to see 20, 25 patients in a day, we're lucky now if we can see 6 because of all of the extra cleaning. Things like waiting, you'll probably be asked to wait in the car because we know from the evidence that a lot of the transmission actually happens in waiting rooms, magazines, people sitting and talking, anywhere where people are talking to each other. So probably you'll be asked to attend on your own. That's difficult if you're scared of going to the dentist or you've got childcare issues. But the reason being that they're not wanting to have people together in waiting rooms. Another thing is you'll probably be asked to wear a mask because again, without social distancing and even with chatting and while we're taking histories, we may ask patients to wear masks to limit the aerosols concentration in the atmosphere. And then the minute you take your mask off, to take quite a strong mouthwash to reduce any load. The thing is nowadays we've realized that people can transmit virus without any symptoms. So we have this thing called universal precautions. We have to assume everybody's got the potential to be infective. And then this is the other bad news, the higher costs. There's no doubt that this additional cost of personal protective equipment, if you're seeing a private dentist in a clinic, that price is probably going to be in part passed to patients. It has to be, because what's different about dentistry and the rest of medicine is it's often provided in private clinics away from government and hospital. So this stuff has to be bought in. And at the moment, the inflated costs that people are having to buy, sometimes this even counterfeit PPE, is adding huge costs to the provision of so much care. Next slide. And this is the other thing, that dentists are opening, and it's great news because they can get back to work. But what we're seeing is a real difficulty in private clinics in the supply chain of the equipment and the protective equipment. So dentists may have to ration it slightly, or they may be running out. So even those that open may, have to close down if they're doing too many of the aerosol procedures that need all of the big stuff. Next one. But it remains, and it's shocking to us working in this field that registered nurses, dentists, cleaners, orderlies, those things, that dentists are the number 4 highest at-risk profession going back to work. Number 3 is our dental nurses, because they do all of the decontamination. And top of that list are the dental hygienists. So I think this shows what we're dealing with. But there again, and I'll talk about that in a second, we know we have a duty to provide care, and we must provide care. But at this time, slowly, it's going to transition from the urgent care to the more routine, but we have to take it step by step. And I'm going to hand on to my colleague, Zikra Alkhayal from Saudi Arabia, to talk a little bit more about how this is working in Saudi Arabia. Thank you.
Thanks, Alison. Hi, my name is Zikra Alkhayal. I'm a pediatric dentist consultant from Saudi Arabia, and a member of the World Federation of Hemophilia Dental Committee. And I will discuss how COVID-19 impacted dentistry in Saudi Arabia. I will be talking about Saudi Arabia, but it may represent all the Gulf states and other countries in the region that have pulled all stops in a structured manner in their attempt to combat the disease. So, COVID-19 pandemic in Saudi Arabia is part of a worldwide pandemic of coronavirus disease in 2019. On March 2nd, the Ministry of Health in Saudi Arabia reported its first confirmed case. And as of 31st of March, there are 85,261 cases with 62,442 recoveries and 503 deaths. Next slide, please. Part of the government precautionary, preventive, and protective measures in the middle of March, Saudi regulators and health authorities recommended that dental offices, dentistry clinics to immediately stop seeing patients except for emergency treatment. And all other dental specialties were actually, during this period, were actually postponed until further notice to reduce the risk of spread. So during that period, teledentistry or mobile dentistry became important in diagnosis, management, prevention, and most important, the psychosocial support for the patients through a phone consultation. And also, during this period, the fear of COVID-19 during the period from the dental practice actually grew during the expansion of the pandemic. As one patient with bleeding disorder described it, dentists are actually the biggest red line now, since during the visit, we have to remove the mask and our faces will be closed and the hands on our mouth, which is a big risk. As of 31st of May, which was last Sunday, complete lockdowns in Saudi Arabia were lifted slowly with guidance. And they were told dental practices have been allowed to go back with guidelines similar and based to international standards and similar things that Alison has discussed. So how will dental practice recovery in Saudi Arabia look like the following the shutdown? I think it will be very slow, for sure, slow recovery, and it will be based upon risk assessment and risk versus benefit of dental treatment during this period where dentistry can be a method of spread. Thank you very much. Next, I will ask now Dr. Maria will share her perspective on the subject.
Hello, everybody. Thank you, Zikra. I'd like to thank the WFH for having me in this very, very nice webinar. And I'm so delighted to be here and share this panel with my dearest colleagues. Thank you very much. So next slide, please. The first case of COVID in Brazil was diagnosed in late February in São Paulo City. And at this time, the disease is just spreading into the interior of the country. Next slide, please. Today, we reached the mark of more than 30,000 deaths in the country. So since that day, we have seen an increasing number of cases and deaths. And unfortunately, the curve of new cases in Brazil is just rising every day. So despite having guidelines for dental treatment of patients with COVID-19 delivered by the Ministry of Health and Dental Societies in Brazil, at the moment, either public and private dental offices are closed for routine care, and the only emergency cases have been managed. So that's the situation that we are dealing in the country right now. Thank you. That's it. Next slide, please.
So that's the kind of doom and gloom. And next slide, please. So it's not all doom and gloom, because I think credit to the dental profession with such high risks, because we know how to deal with cross-infection. There have been little or no clusters of patients' infection that have been linked to dental practice. In fact, the biggest cluster was a dental conference in Canada, where a huge number of dentists collected together, and it was the conferences. Again, it's that social contact. But what we've done to limit risk at the moment is that we have overnight embraced teledentistry. It's been there actually since the 90s. And this has been a way that we can support and offer treatment and advice to patients. Teledentistry is the way we diagnose and the way we give a treatment plan to patients so that we can actually help them at a distance, especially if they're cocooning or they have their own medical risks. For example, we're learning more and more about who are the patients who are at risk. So the first thing that I think is really important is not to poo-poo this. This is a really powerful way of getting rid of pain, or certainly getting advice, because with the right information, and if patients prepare and can describe what they are experiencing, we can make a pretty good virtual diagnosis of what the problem is. Identify whether somebody's got an emergency, or whether it can be dealt with pain management or a prescription, for example. Prescriptions are usually only required for big infections, but we can see that. And certainly all of the patients that we've used teledentistry, we've asked them to take photographs of their problems. And I've been blown away by the quality of the photographs that we've got. I mean, I've spent so many courses and huge amounts of money on clinical photography, and now patients are sending things that I would be proud to put up on a lecture screen. This can tell us whether a tooth is unsavable, whether it would be a very complex extraction, whether it looks like there's an infection, whether it's an ulcer that needs an urgent look at. So pain management has been one of the things that in the bleeding disorders community I saw was really people needed a lot of help. that this is often a difficult situation to make the right choice for pain management. And we have a great new section in the WFH guidelines. But generally, pain in the teeth can be managed by paracetamol taken to maximum dose. But it's not enough for a severe toothache. And the best pain relief to take alongside that is not an opioid. It's something like Icoxia. It's whatever you can take for your joint pain. So we would sort of be prescribing or recommending Icoxia 90 milligrams or even 120 milligrams once a day, because dental pain is inflammatory. So anti-inflammatories work the best. And of course, Icoxia is not contraindicated for people with bleeding disorders unless they've got a serious cardiac condition. General advice as well. We found that people needed advice and reassurance that if they did have a problem, that they'd got somewhere to go. And also we could advise them on small problems or things they were worrying about, teething or things like that. A thing that I've done a lot of was if people break their teeth, and if you've got hemophilia or a bleeding condition, if you've got a sharp tooth, then it can cause problems with your tongue, it can cause a tongue bleed, it can cause an ulcer. So what people didn't realize is you can buy temporary fillings at the pharmacy. So I have been using teledentistry to mentor people's families or people themselves, mixing the temporary filling and putting it in the hole. And that will last for 3 or 4 weeks and stop the cold going down there. So really useful things can be done via teledentistry. Another thing that I've been doing, next slide please, is we realized that patients were going to have to see dentists that they'd perhaps never seen before, or work with hemophilia teams that were unfamiliar. So we did it for Ireland with the Irish Hemophilia Society first, and then the EHC then put the set of resources on their website, and I know WFH are going to do the same. An algorithm that could be used with the whole team, and I would talk patients through and also mentor dentists of how they were going to do all the correct things and make the right choices, so patients could go and have a root canal, the first stage, or to have teeth out. And this has been key, the telementoring of dentists. We've always had dentists who are terrified of seeing people with bleeding disorders. But I found that with telementoring, for the first time, dentists had the confidence. And this is definitely something that I will carry on doing throughout the rest of my career, I think, is teledentistry to give patients confidence and to give dentists confidence. I'm going to hand over to my colleague Zikra, who's going to talk about risk assessing and using the tools that we've got for patients. Thank you, Zikra.
Thank you, Alison. A question. I have been involved in patients who are actually taking ibuprofen, and some people are taking a lot of Tylenol. Can you give us an idea of the user? I mean, I've told them not to use ibuprofen, and now it's good to hear from the other drug that you have recommended. So, can you tell us about the maximum dose of the Tylenol? Because it is scary that patients are taking some of the pain medication and they need to know that there is a maximum.
I think this is a really important thing about educating patients. For us, most definitely the best paracetamol, best combination for dentistry is paracetamol 1 gram 3 times a day if you've got any liver impairment, 4 times a day, 1 gram of paracetamol, and then on top of that, the Icoxia, because the two together work really well. And it's so much better to take a combination of 2 pain relief for dentistry than is to overdose on 1 pain relief. So I think there is no doubt that dental pain is excruciating. You can't last for it for more than 2 or 3 days. It impacts your relationships, your food, your sleep. And at this time when everybody is stressed, educating children, stressed, then I think we need to not be scared of taking pain relief, but being very careful about the dosages. But Icoxia is stomach sparing, so it means that we're not at risk of GI bleeding. And I think that's the really important thing, as opposed to ibuprofen. But it's great for dentistry. So thank you. I hope that helps.
Next slide, please. Next. Okay, individuals with bleeding disorder, they are a special group of dental patients. They're not prone to have more dental decay or oral disease or gum conditions, but because many that I know at least, they don't like to brush their teeth. They don't like to take charge of themselves, and they don't like to floss. They worry about bleeding from the mouth, and they may fear it, and they don't know it's not brushing that's causing the bleeding. And also they don't like to go to the dentist because of fear from mouth bleeds post any kind of procedure. And more importantly, they actually don't trust, many of them don't trust the dentist because they don't think the dentist know enough on their condition, which is somewhat understandable because as not all dentists actually understand how to take care of patients with bleeding disorder. So we end up with dental neglect and symptomatic model of care in the dental practice. And COVID-19, I think we have seen that the fear gets heightened and we will be ending up with more oral disease if we're not taking care of ourselves. Okay, next slide, please. What are the dental emergencies I have seen during this time myself? I have seen for sure dental pain that varies from a very simple pain that can be taken care by just a simple brushing their teeth or by pain management, or so severe that causes swelling that we end up giving antibiotics. I have seen, actually I've communicated and managed bleeding post teeth, primary baby teeth coming out, and then permanent teeth coming in. And to tell you the truth, I haven't seen much dental trauma myself because also patients are taking care that they don't want to have an emergency to come to the hospital. Next. Next slide, please. So before that. So basically, before we go on, I'd like you to know that when we try to manage patients with bleeding disorder, we have to think for four main factors. First of all, we need to know what is the risk of bleeding. Are you a mild bleeder? Are you a moderate bleeder? Are you a severe bleeder? We need to know that. It's a medical history, and we need to know, and you need to know, and we need to know the hematologist. And also we need to know what kind of procedure you're going through. Is it what kind of procedure, dental procedure? Is it an exam versus an extraction? Also, we do need to know that there is a, do we need a factor? And more importantly, even if we don't need a factor or need a factor, we need to make sure that we do local measures. Next slides. I think the most important when you deal personally in anything to do dentally with bleeding disorder is having a good team. And in my experience, the hematology team are one of the best teams I have worked with in terms of how they take care of their patients. So it's very important to have a very good communication with your team before you do any dental treatment that may cause bleeding. Dr. Alison has come up with a very nice passport that I'm using in any way I can. Her permission, it's supposed to be saying her permission, where she identified, it's like a traffic light, 3 areas. The green to go ahead as a patient, that you can go ahead, you can do an exam, you can do an x-ray, you can do a facial sealant, you can do some whitening, you can do fluoride application, you can do simple restoration that doesn't need invasive, just actually on the tooth, simple restorations. You can take impressions without impressions for a complete denture. And then you can, very important, have some locals, especially in the upper mouth, region of the mouth, where you actually can do and go ahead and not be worried. But when it comes to the yellow, you have to ask and think, you know, when you have to do orthodontic treatment. What I find with orthodontic treatment, most of the bleeding that I have is because people don't brush their teeth. And it's very important. You do not start any kind of orthodontic treatment unless you are very good, excellent in oral hygiene. Your mouth is clean. Because what happens, the bleed you see is not only from the ortho, it's actually because you are not taking care. So This is one of the things that I have learned. And also some things that are used in the dentistry, like a clamp that we can actually expose the tooth only to treat it during nerve treatment. And some of the nerve treatment, we need to know, because moderate and severe, you need to ask and think. Ask your hematology team and think about it. Stop and consult, you don't do it. Even if you do it, you should be a center that is prepared to take care of any issues. It's the hematology team. Of course, the implant, which many people avoid to do, major periodontal surgeries, a block, inferior dental block, which is basically a block that treats you. You give it injection at the bottom, which goes into the bone. This is a no-no because you can have bleeds without seeing. And extractions, removing a tooth, which are probably going to be your most, or has been the most procedure to be done in dental. This, you have to have clear communication with your medical team, the hematology team. Next. So in COVID-19, again, I'm basing all, which is amazing colors. And I thank you, Alison, who did this beautiful work. Sometimes what was discussed earlier will not happen. I must say, I've been doing symptomatic treatment. I've been doing pain management. I have been doing antibiotics. I have been doing local measures. But sometimes this will not work. And later on, after the recovery, you may have to. Things can't stay still. You have to. Provided with the prevention that Maria will talk about, I think there are 4 main procedures that we tend to say they are real emergencies. Number 1, the root canal or the pulp therapy. So if a block is needed, have you contacted your hemophilia team? If no, you should have pain management and you should contact. Or if yes, then there's no issues. Just proceed and everything will be okay. That goes for root canal or pulp therapy. These are, if the pain cannot, you cannot sleep all night, nothing makes it better, you've been on pain medication for many weeks or 1 week or 2, you should take care of it. Second one would be drainage or incisions of abscess. If the abscess require a surgical drain required, you have to contact the hemophilia team. If you didn't contact, you still have to have a high antibiotic spectrum, that analgesia until you're able to actually get the right hemostatic measures, and whether it's factor, whether it's local. If the incision contact, yes, you can go ahead, no issue, you can do any local anesthetic. When we come to dental extractions, you have to contact your team. If yes, you can proceed, no issues. And very important, the local measures in this instance. For 5 days post-extraction, you have to use local pressure. Bite, bite, bite. The first 24 hours is very important. Continuing to the 5 days afterwards. You don't rinse. Whatever rinse you're given, like tranexamic acid, if you know it, you crush it and you put it in a gauze and you put it in the mouth and you bite. You don't smoke, or you limit smoke. And you put packs. You need to stabilize this clot. It's not like you cannot stop as a bleed in many people. It's because you cannot stabilize it as in your hemophilia, but it's that pressure that is needed to get the things working even after factor. So if no, again, you have to treat with analgesia or consider first stage root canal, which probably needed like a simple injection, and try to do it. But I still think analgesia until you're able to talk to your hematology team. Next, dental trauma. For dental trauma, you're hitting your kid who fell and suddenly the teeth are out. I don't know what to do. He's bleeding. Everybody's scared. Of course, it happens even with people without bleeding disorder. So if there is any soft tissue bleeding or laceration, did you contact the hemophilia team? You have to contact the hemophilia team so they can give you the hemostatic management plan. They are so important. They are actually, for me, they're the success for my treatment. They're a backup. And if yes, then is it working? No. then you have to stabilize the tooth as much as possible, and you have to contact the team again. If no, you stabilize and you have to contact, because I think very important in trauma is that you have a constant someone who knows about your trauma, because it may also have a head trauma, and that head trauma will need a medical person. But if you didn't have any of that, if you contacted the team and you didn't have head trauma and it's just the trauma, you can just deal with it. The dentist will know through our international guidelines. Next. So still, we prefer symptomatic management with pain management. However, at this time, and as we go hopefully into normal, which will take long recovery, communication should be there between the hematologist, the dentist, and most important, you should start taking charge of your own health, both in when you need to do a treatment and also when it comes to prevention, which Dr. Maria will now talk about and let us know. Next.
Thank you, Zikra. And why at this time of COVID-19 prevention is so important? So prevention is an important area of healthcare. In dentistry, prevention is the key for reaching a good oral health that culminates in the prevention of dental problems, prevention of infectious disease, pain, and bleeding in the mouth. Usually, prevention in dentistry involves the direct contact of the patients with the dentists, and it includes patient education and consolidation of habits such as brushing, use of fluorides, and flossing. Next slide, please. But now, at the time of COVID-19, prevention became even more important because almost of dental units are closed for routine care, or they're only dealing with dental emergencies. So what to do? So since COVID-19 is a new disease and there is a limited information, it is important for patients to obtain reliable information from trusty sources. And at the same time, it's important to patients to keep in contact with their healthcare providers and the dentists, of course. The role of institutions such as WFH in organizing and disseminating guidelines is of vital importance to the community of patients and professionals involved in patients' care. And at the same time, technology can assist patients' access to the dentist. The use of teledentistry or even WhatsApp can facilitate the contact between patients and the dentist. Next slide, please. In addition to learn about new technologies, prevention also includes changes in our behavioral patterns aimed at maintaining preventing health in general. So improving self-care, for instance, washing hands before and after brushing, taking care of our own oral hygiene tools, wearing masks, etiquette when coughing or sneezing, beyond physical distance, are now behaviors that must remain for some times in our life. Next slide, please. So along with self-care improvement, patients need to pay attention in their oral health, improving oral hygiene, and at the same time, being mindful with habits that may cause traumas or bleeding in the mouth. Next slide, please. So in prevention at this time, prevention has to be an important part of the care of patients. Prevention in dentistry is always important, but mostly at this time of COVID-19, patient must preserve and promote his own health. And the health communications and new media landscape demonstrates the extent to which modern digital technology can serve as the most practical and efficient way to distribute health-related information. That's what I would like to say at the moment. We don't have too much to add to the regular dental treatment, but now patients need to be aware how prevention of trauma and bleeding in the mouth should be routine at daily life. Thank you. That's it.
All right, thank you, Elvira, and Alison and Zikra as well, for some excellent presentations on various aspects of dentistry during the COVID-19 pandemic. I want to, if we go back one slide, yes, I do want to give special acknowledgement to the Hemophilia Alliance, which has funded this program. And the Hemophilia Alliance is an organization here in the United States that has been funding scholarships for people to come to in-person meetings, and they have kindly agreed to fund our distance telemeetings going forward during this period of time, and so we're very appreciative to them. Next. So the question and answer period, we have some questions. Let's leave these up, Antonio, but I wanna get to a big one that has run through the crowd a little bit, and that one, it really has to do with the risk of infection, and so we've got two sets of risks here. We've got the risk to the dentist and the personnel that are in the dental office, and then we've got the risk to the patient. Can you perhaps, in a very brief way, just define the risk to the dentist and the dental personnel, and then define the risk to the patient, and what's been done to mitigate both of those? I think there's a little confusion there.
Yeah.
Alison, do you want to lead up?
Yeah, okay. The risks are there. You can see that the risks are there. However, I think that many of us who've been working at the front line with the correct equipment and with the correct protocols, the risk is small, both to patient and dentist, if things are done properly. In fact, we've already identified that it's probably the waiting room and the journey and those sort of things that are the real risk. But if you're going to a dentist, you want to see that those things are in place. If your dentist has got a full set of kit, or is wearing visors or a special mask, or has asked you to do something different, I would be very confident that they were taking this seriously. So I would say then that the risk is very small, because we're really good at cross-infection. But if you're seeing somebody who is a bit gung-ho, or is downplaying it and saying, oh, don't worry, there's not a problem, then I think the risk is there. So I think you can see it in practice. If your dentist is telling you to do things differently, is looking different, then I think the risks are small. Dentists have died, but that's before we knew what the problem was. And that's where people were asymptomatic, and before all the evidence was there to show that asymptomatic patients could transmit. That's when the Max Fax surgeons died in Serbia. That's when the surgeons died in Italy. But now we know our problem is that we're having to do things differently, but patients are pushing us. We're already seeing patients are getting angry with us because we're being difficult, that we won't do this or we can't do this. So I think that dentists are very good at this, and they will know what's possible, but you need to see a difference in their practice. And if you're not seeing this, then it's not the right time to be going. So the risks are small because we're good at what we're doing, and we haven't been in clusters. I think that's what I'd like to say, Glenn. The real risks, we still don't know. But what I would say is we're not seeing clusters around dental practices, or even emergency dental centers.
I think that's a very important point. And an earlier one you made as well about universal precautions.
Yes.
My dentist has been practicing universal precautions since HIV was around, and you just assume everybody's infected. And if you do that, then the patient, the dentist, and his or her personnel are also going to be practicing that.
Yeah.
Be safe. Okay, we've got some questions here for severe bleeding. If the bleeding stops after receiving factor but resumes again after 2 to 3 days, what's an economic way to control it? Brief answers, please, because I want to get
Okay,
to more
brief
questions.
answer is the economic way is to not have the bleed in the first place, that we have all of the technology, but it's 3 people working together. It's the dentist doing the local measures, which mean that the clot is stabilized. It means the right factor beforehand. It means the patient not using, being really careful, not smoking, really soft diet, not so that they're not traumatizing and not over rinsing. But it depends what your bleeding disorder is. Antifibrinolytics post-operatively as tranexamic acid tablets will help tremendously. But if you've got a bleed, then it's a mixture between the dentist removing the clot, repacking the clot, and possibly more factor, but more often than not, with packing the clot, with extreme pressure put on that on the area, then we can stop most bleeds without needing factor. However, you should not have a prolonged bleed, because the last thing we want is people having really bleeds in the mouth are traumatic. They taste horrible. They traumatize you. So, but it's a mixture. Dentist and hemostatic measures, but really post-operative tranexamic acid, either as a mouth rinse, a gel, or best of all, tablets will actually be the most economic way to control post-operative bleeding. We prescribe them to every patient who is able to take them post-operatively having dental, because it's the fibrin, it's the defect in the fibrin pathway, which often causes the rebleed. So antifibrinolytics is the economic way.
All right, thank you. And then Elvira, a question for you that is similar. Perhaps you can add to this. After the use of tranexamic acid for gum bleeding, some patients still experience repeat bleeding. How can we control it without factor?
Tough question. So anyhow, it'd be very nice, very important to know why you are having gum bleeding. Why? Do you have any trauma? Do you have a periodontal disease? What's going on? So to be fast, so we use topical tranexamic acid for a long time. Just crush a tablet, mix with a drop of water, make a paste, put in a gauze, press over the place where it's bleeding, and press without taking off for at least 30 minutes and stay there to try to control. Okay? They might find, I don't know where the patient is, but there is some tranexamic gel, 8% tranexamic gel available that works very, very nicely. So you can use this to put some drops of this gel in the top of the gauze, and then again press against the site of bleeding. But I have seen a lot of patients bleeding for a long time from the gum, and sometimes with very, very severe consequences. So I would say that after some time, someone trying to control the bleeding, if the bleeding haven't stopped, please just contact your dentist and your hematologist, that you might need to see your dentist in person. So after doing this, don't wait so much to ask for help. Please don't stay bleeding at home.
All right,
That's
thank
it.
you, Elvira. A third question for Zikra. Is it advisable for children with hemophilia to extract teeth, or should they wait until the tooth falls out itself? And what are home remedies for, which home remedies are good for stopping the bleeding if it occurs? So.
Wait until the tooth falls out itself. I have to tell you that most of the problem that I have with children, usually they're patients with platelets issues, such as von Willebrand, but patients with hemophilia, the problem again, it's not the tooth falling out, it's the fact you never brushed your children's teeth, so you have plaque. So even me, if I stop for one day, they will be bleeding. So it's very important to answer the question until the tooth falls out itself. However, what are the home remedies? In case, for instance, the tooth came out, of course, there are time limits. We have plus or minus, like the lower teeth should come out at 6 years of age. So you need to know when these teeth need to come out. for sure I will not extract because I want to extract teeth because they're baby teeth, unless they're causing major issue and pain. What are the home remedies that are good for stopping the bleeding? Home remedies: pressure, gauze, or if you have a clean cloth, but it has to be clean, a gauze will be better. With little wet, it's always good to be having a little bit, not dry, and bite at least for 20 minutes. 20 minutes is very important. Sometimes people use ice to make it kind of shrink. Also tea, but I don't know if it's because of the pressure. Tea bag, cold tea bag. I don't know if it's because of the pressure or it's because of the tea. There's no studies, there's just home remedies. So basically ice, pressure, tea, and of course, if you are a hemophilia patient, I'm sure you have a supply of tranexamic acid tablets. Just crush, like Dr. Maria said, you crush it. You either place on top of the area or in a gauze, like 5 cc water or 10 cc water in one tablet. You put it and you put it locally, because a lot of effect happens locally more than even taking it systemically, tranexamic acid, because of the antifibrinolytic effect in the mouth. So pressure, and nothing fails. Also, don't forget thrombin if you have, but I don't want to go into more expensive stuff because you actually asked me about home remedies. And again, in my personal experience, and maybe hemophilia don't bleed as much as for teeth out as much as they're scared of the other models. Thank you.
All right, thank you, Zikra. We've had some questions about going to the dentist, and if I can get brief answers from you, should elective procedures be done at this period of time?
In my point of view, I think if a tooth is going to deteriorate, if people with hemophilia have got a tooth that they're worried about that's going to really deteriorate, I think the risks of having that done are fine. I think we shouldn't let our health deteriorate, but anything that can wait, I think should wait, only because it's difficult, because of traveling. We should be cocooning and social distancing where possible, but don't let your health deteriorate.
And
so yes, yeah, thank you.
What about cleaning?
For cleaning, I think that the best cleaning of your teeth is done at home. I think that get some disclosing tablets from your chemist, which will actually stain the plaque, that you can clean it off, and ask for a teledentistry appointment with good instruction. If you've got active periodontal disease or you've got an infected gum condition, then I think with the PPE, then I think hygienists are providing some treatment, but generally with hand scaling, with hand instruments. So just to go and have stains removed, there's very little evidence that that helps. If you've just got some calculus on and you will floss and brush your teeth, the best cleaning is done at home at the moment. But don't be scared to go if you've got a really severe gum condition, if you've got Glanzmann's and you need to have your gum condition really, really healthy. If you've got von Willebrand's 3 and you need your gums healthy, then I would say don't stay away from it, but do the work yourself.
Okay,
I don't know what everybody else thinks, but if that's my view.
Let me move on to some other questions.
Okay.
There's a question on emicizumab, Hemlibra, and the question is, have any patients on Hemlibra required dental treatment during COVID-19? And there isn't a lot of information generated regarding procedures for these patients. So I don't know that this is a COVID-19 specific question. I think it's more a question on the use of Hemlibra and doing dental procedures. Have any of you had experience with that? I
can take that question unless anybody else wants to.
No, go ahead. Go ahead.
Yeah, I have. We have switched patients in Ireland to Hemlibra. I've also been advising the patients in Europe, lots of whom with inhibitors have gone on to Hemlibra. Hemlibra shows great promise for being able to make lots and lots of dental procedures completely without risk, because it's leaving people at about 12 to 14%. That's safe for fillings, for most cleanings and whatever. The data is limited at the moment, but it's also looking like with local measures, and antifibrinolytics, single dental extractions with the right work from the dentist can possibly be done with no factor replacement. Saying that there have been bleeds, but we think that's happened where they've just been relying on Hemophilia. So what I would say is we need clear guidance, but it's looking really positive. And this is life-changing because this takes the worry away of going to the dentist, you know, to have just certainly the ordinary procedures. If you're on Hemophilia and you need your wisdom teeth out, you need implants, most definitely you would still need supplementation. Nova 7 if you've got inhibitors or your factor of choice. But for simple dental extractions, looking very positive, but only if the dentist does the special stuff as well. That's in a nutshell.
All right,
But
thank
brilliant.
you.
Yeah, thank you.
There was a little confusion about ibuprofen. I want to just point out that ibuprofen is not recommended in persons with bleeding disorders. It has a small inhibitory effect on platelets, and so it really should not be used.
Correct.
An additional question came about the need for chronic constant pain medication because of a problem during this period of time. And Alison, you referred to paracetamol, acetaminophen.
Yeah.
Can people use it for a month or 2 months at a time?
Yeah.
The
only time when I would advise somebody to stay with toothache for a month is if they have had COVID and they need to wait their 39 days to make sure they've cleared it. For me, who's doing teledentistry, if I can't control somebody's pain within 10 days, I would be wanting them to come in, because at any time that's showing us that that could turn into an abscess or could turn into really severe pain. So I take a pain scale, and then I wouldn't want people living in chronic pain. This could go on for a long time, but certainly short term, some of the toothaches can also, if it's a pulp inflammation, a small dose of steroids can help. But I don't want people in pain, and we shouldn't be in pain for more than 2 weeks. And if you can't get access to a dentist and you have a hemophilia, then have your national member organization advocate for you. You shouldn't be able to not access care because of your bleeding disorder. This should be your personal choice rather than because of your bleeding disorder. Yeah. So I don't recommend anybody being in pain for toothache for more than 2 or 3 weeks. You can't deal with it, and at any time it can switch into an acute pain.
Okay, thank you. There was a general question, perhaps that I addressed early, about the risk of COVID-19 in bleeding disorders. So let me just repeat that there is no increased risk if you have any sort of bleeding disorder of acquiring COVID-19. Once you have COVID-19, if you have acquired it, there are risk factors such as diabetes, heart disease, and so on that will increase your chances of getting a severe disease and potentially getting a very severe disease requiring ICU admission in a hospital. If that occurs, then your bleeding disorder needs to be very carefully monitored, because there is good evidence that there is a whole series of thrombotic events that occur in the lungs as well as in other tissues with COVID-19 in a very serious state. And so if you combine hemophilia with the risk of thrombosis and the measures that are taken to prevent that risk, that requires careful management, taking into account your bleeding disorder. And that means contact with your hemophilia treatment center if that's the case. There was a question on security and privacy with teledentistry. Would any of you like to comment on that? I also can make a comment based upon the telemedicine that we're involved with here in the United States too.
From my point of view, I think telemedicine has to be, and teledentistry has to be, have all of the confidentiality and consent, and there is a process for doing it properly. For example, teledentistry isn't a WhatsApp call. I think that So yes, I think that all notes need notating on a clinical note. We're lucky we have an electronic patient record, but there are teledentistry or telemedicine apps where your telephone number is not shared and where the data is secure. I think that as we move into telemedicine, then we have to respect all of the GDPR and all of the data protection. We also have to inform patients that this is the limited diagnosis and that we will be, and making sure we have permission to share that data if we're wanting to send photographs on to somebody else. So it's so well notated, well documented, and with a proper consent process and a data sharing agreement. So I think you need a proper telemedicine or teledentistry program to be able to do that. I don't know what you've got to add, Zikra or Glenn, if you've got something to add.
Yeah, I think it will depend upon the country, and it's really up to you to figure out if the system that you're using provides the protections. I do think that in this period of time, the protections have probably been loosened up a little bit. We're doing a lot of Zoom calls, and some institutions have had Zoom up and running for a couple of years and have all the protections in place. Others are just putting it in place. I'm not totally clear that everything is fully protected. So that's something that each person, I think, has to figure out for the system that they're using.
I can add, I'm talking about actually in the virtual, but basically, I think areas, bleeding disorder, this communication, teledentistry is nothing new. Telemedicine is nothing new. Actually, WHO now have a big document about it, but they clearly state what you stated, Dr. Glenn and Dr. Alison. There should be some guidelines. There should be, like doing a research, you have to have guidelines. You have to hide. You can never be totally safe, but you take the appropriate measures to make sure it's as safe and as ethical and as, because benefits will outweigh risk. And personally, during COVID, for me, it worked so well. It was much needed. We cannot deny it anymore. Teledentistry in education, in the dental home thinking, in how you tell the patient psychosocially. But the logistics, it has to be a group, and we already have the medical people already using it in dermatology and other places. So this is my point in the teledentistry part.
Good point. Thank you, Zikra. We have a question from the NHF in the United States. They'd like to know if they can use your algorithm on their website, Alison.
Absolutely, it's for free open access, and it appeared first on the Irish Hemophilia Society. We will be opening it up to WFH, and the EHC have it on their website. It's all for download. On there also is a resource which is to help patients prepare for their consult, so that they've got the right information. They've got the right information for a good teleconsult. We've also got letters for dentists explaining about haemophilia, for example, if you haven't met them before. So that's what we've done. We're there, the resources are for everybody, with pleasure.
Okay. Baiba Zamali has pointed out that there are tannins in the tea, and perhaps that might have an effect on coagulation. I don't know if there's any research that's been done on tannins.
No, it's I think it's the pressure, but I mean, who knows? And I think that patients with haemophilia would tell us that ice creams, ice lollies, ice pops, tea bags work. And I think that's what home remedies are about. But I don't think it's the tannins. I think it's the pressure, because it's a different type of tannin that would help with the anticoagulation. But Glenn, can I answer Brian O'Mahony's question? Would you mind? Because this is quite an interesting one moving forward. Have we got time, or are we running out of time?
What is it?
It's about the use of hypochlorous and fogging machines to decontaminate dental rooms.
Go ahead.
Yeah, I think this is going forward. What we're going to all in the dental practices are all looking at the way that they can improve patient safety, their own safety, but more than that, do it in a timely fashion so that we can offer more access to care. So people are using HEPA filters, they're having air purification systems. We have chosen to go with fogging machines. This is the way that you can use, you can produce a chemical to decontaminate your surgery. And the advantage about hypochlorous acid is that it can, at very low concentrations, is about 3 times as effective as bleach, sodium hypochlorite. So we can fog using a machine that looks a little bit like a vacuum cleaner. We can blow a fog around around our dental rooms and decontaminate the air. We've never had to think about decontaminating the air. So I think this is the fashion. It's something that we're looking at, and that dental practices are looking at the pH and the concentration to make sure it's effective against COVID. But it's the one thing that means we could probably decontaminate a dental room in 5 minutes rather than an hour. So that's a fogging machine. So if you see people walking around the waiting rooms blowing what looks like a sort of wet mist, that's what's happening. But the good thing about hypochlorous acid is that it's environmentally friendly. It's not going to trigger asthma and things like that bleaches would if you were doing exactly the same with bleach. So I think we're going to see all of these things happening. Yeah.
No risk of inhalation.
No, because the whole thing is it's not stable, and it works within about sort of 30 minutes, 30 seconds, no risk whatsoever. You can do it straight next to someone. But if you were doing it with bleach or with hypochlorite, then people don't like that. But this is no risk, and that's the whole beauty of it. It's at 500 parts per million, so it's at such a low concentration, but it's bactericidal. It's acted against previous COVID coronaviruses and things like norovirus, and it's on the FDA and whatever as an effective chemical against COVID. So we're seeing this, and certainly that's the route that we're going, because I want to get patients in with toothache safely. And I think that's what we need to do for ourselves. We need to now be creative and find what's out there as we get more information, so we can provide dentistry, because we need to, because people can't live in pain.
Okay, there have been a few more questions about telemedicine, and a question that Zoom is not HIPAA compliant. I think you have to investigate at your particular institution. The one that I attend has been doing Zoom in a HIPAA compliant way for about 2 or 3 years now. So check for yourself locally as to what your institution, what safeguards your institution can provide. Roshni Kulkarni asks if there's a lower incidence of dental disease in patients on prophylaxis.
Does anyone want to answer that? Alvira?
Thank you. I don't know. I don't think so. I think this is more dental infections or dental diseases more related with oral hygiene. It depends on how long, or how much, or how nicely you keep your mouth clean. So it's just regarding this. So it doesn't matter what type of disease you have, in my opinion at least. I don't know, Alison, what you think?
I would say that people with prophylaxis have the opportunity to have better dental disease because they have their factor at home, they're more confident. What I've seen during these COVID-19 times is people I've never seen, people with platelet function defects, people with mild hemophilia who aren't often in touch with services and haven't been to the dentist for years. They're not as empowered. So I would probably say that with prophylaxis, people have got more confidence or whatever, but there's no data. There's so little dental data considering it's such a big issue. What we know is that people with hemophilia have far worse gum disease, 5 times worse gum disease than the general public. Regarding decay, it is a variable. It depends. Decay is a socioeconomic disease. So the thing that will predict whether somebody has caries is generally their socioeconomic status. Can they afford to go? Are they living somewhere where there's a health system? So sadly, this is the one thing that dental disease is strongly related to people's socioeconomic status, and it's one of the biggest things why a universal health cover would actually sort out dental problems for a lot of people. Sadly, a lot of people still can't afford to go to the dentist, and there's nothing in place for them. So I think it's money rather than prophylaxis, if I'm honest with you, and that's always a confounder in every single study.
Thank you, Alison. We have had a couple of more questions about pain medications, and so maybe we can just get a little more clarification.
Okay.
If a person can't take paracetamol, what other medications can they take?
Does somebody want to answer that? Eteroxycob, which is Arcoxia, if you've got it, would be the second line, and a lot of people go for that first. So that would be
Say that again. Say that again, Alison.
Okay.
And I'm not sure I recognize that. So
Arcoxica, Eteroxip, or I don't know how you would say it in. Let me write it down for you. It's
a COX-2 inhibitor, it sounds like.
It's a COX-2 inhibitor, yeah. It's a COX-2 inhibitor. So in Ireland, it would be called, I think it's Eteroxycob, Eterocoxib. Arcoxia, we would call it.
Okay, in Elvira and Zikra, anything else from your geographic perspectives that can be used?
Actually, this is one of the hardest questions because we all know that Profen is the best for dental pain, but we cannot take Profen. So for us as children, I'm using Tylenol for my group. However, I know in North America, they also, but it cannot be used under the age of 12, is Solpadeine, which is codeine and Tylenol. But Alison was telling me that it doesn't work. Yeah. So for me, it's a Tylenol psychologically, I feel it has codeine. Even in children above 12, you can use it. So to me, I'm limited really to Tylenol, but it's like 10 to 15 milligram per kilogram per dose. Yeah. Every 4 to 6 hours PRN. So really, it's a very difficult. I'd love to use Profen. That's if you're here, like we tell our patients not to use Profen. But what's interesting, when you read about Profen, it's also good at stopping bleeding. So that's something I get confused about in terms of why shouldn't we not use Profen? I know it's about the stomach. I know I'm putting it out because to me, Profen is number one for children when they have dental pain. But I know I never used it for my patients.
Yeah. Glenn, also tramadol as a first-line opioid would be about the best opioid if that was the line that you were going on. Probably 50 milligrams to 100 milligrams of tramadol. But then that doesn't really get rid of the inflammatory, but it helps people cope with the pain. I've checked, Etoricoxib is Arcoxia. So it's recommended by the WFH guidelines for joint pain. So it would be the same drug.
Can I add one thing?
Yeah.
I think it's very important to stress here that if you have pain in the mouth, of course you have to use pain medication. Of course you have to, but not so long. As you said before, Alison, it's not about the dosage or for how long. It's about why you are having pain. So sometimes you have pain because you have infection. So you have to treat with antibiotics or to add more drugs to control, or even have a dental treatment to control the pain. So of course you can use paracetamol. Here in Brazil, we have Dipyron that I know it's not allowed in all countries around the world, but we do use a lot of Dipyron. But again, I think it's not about how long and how much, but why are you having pain, and how conditions you have now to treat it, and don't stay in pain for long at home. Try to keep or reach orientation and from your team and try to fix this.
Yeah. Yeah, Glenn, one of the biggest things that has struck me as a dentist is that most pains that people experience, whether it be a joint pain, or they're waiting for a hip operation, they have chronic pains, dental pain is incredibly easy to sort out. That one of the things that's made me kind of be glad of what my job is at the moment is that within an hour, I can get somebody out of pain, either with the first stage of a root canal, just taking the nerve out of their tooth, or removing the tooth. And that's an amazing thing about dentistry. And that's very sad when people can't access care, because actually the best pain relief treatment is to actually have the treatment, because we can in an hour get people out of pain. And that's really powerful. And I think that's really the message I would like to say to people, please, that pain relief is an interim thing, and that you should seek care and not be scared of care, but just make sure that your dentist and you are taking good precautions to go and have that treatment. But nobody should be in pain. And a dental extraction is the thing that will cause least aerosol, much less than a cleaning or something like that. So I wouldn't like to see people relying on painkillers, especially if it's not working for them.
But it's Tylenol is the first drug of choice, basically.
Yeah.
And with the maximum dose.
All right, well, thank you for that. There's perhaps one last question. There have been a recurrent theme through some of these questions about gum bleeding, recurrent gum bleeding. And I know you all have covered this, but maybe one last time, go through, if people are having gum bleeding, they're not going to the dentist now, what should they do? Should they continue to brush to strengthen their gums, get rid of the plaque? What do you recommend?
I would say myself that this is a massive gap in hemophilia and von Willebrand's care pathways. It's like a joint. Once you've got a target joint, you're going to have bleeding happening. So we know, even with people with Glanzmann's, that if people have a hygienist and look after their gums, and it's part of their care pathway, it's not ignored, they're not going to have gum bleeding. However, gum disease is very common. It's just that in people with bleeding disorders, once the gums are inflamed because of plaque, it's very difficult. And you know, people with von Willebrand's 3 live with blood in their mouths every day. So the first thing to do, in my view, is that you need to perhaps is put yourself on a chlorhexidine Corsadil. You can buy it over the counter, mouthwash or gel, because that will actually reduce the inflammation, but you should be on that for no longer than 1 month. You should then buy yourself some disclosing tablets, which are going to stain where the plaque is on your teeth. So with your toothbrush, you can very carefully brush and make sure that you're taking the plaque off, because it's the plaque that will be irritating the gums. So it means that very carefully you can brush with a medium or a soft toothbrush and remove the very plaque which is causing that inflammation. The bacteria and the acids from the plaque are what are irritating the gums. So the short term is, if you can't see a dentist, then you're going to work for a mouthwash, and then be careful with brushing your teeth. But if you don't brush the plaque off, it will get worse and worse. Then after brushing, if it's bleeding, you need to have ice in your mouth. So you could suck on ice. You could also crush the tranexamic acid tablets that we talked about and press them on the areas, or take a mouthwash, leave it in your mouth for 2 minutes, and then gently spit it out. That will help stabilize the clots. So there's no quick fix once you've got gum disease. For people some people are at bigger risk if they've got diabetes, for example. They have a much bigger risk of gum disease, but it's a big gap. And I wish it was in every guideline, that it was that we took it seriously. It's just like a target joint. Once those gums are out of condition, for somebody with hemophilia, it's incredibly difficult to get them back, but we can. And we have a new study coming out to show that just careful brushing can bring the gums back. But during COVID, chlorhexidine mouthwash or gel, and then very careful targeted brushing. That's my view. I don't know if anybody's got anything else.
Elvira, Zikra, any final comments?
Prevention and
That's the word.
yes,
Yeah, but it's the same as joints. Yeah.
Preventing disease and preventing bleeding. When I first joined, I'm in King Faisal. We treat a lot of special patients. So when I was involved, I have to say thank you to the hematology team who work day and night to make sure their patients are good. I think it's our, just one thing, the patient with hemophilia or bleeding disorder are the best patients to put the preventive model in. Because caries is preventable by doing the right thing. Gum disease is preventable by doing the right thing. And one more thing is that I started thinking, I remember when I was specializing in America, I used to so worry when I got a one patient hemophilia, and I was thinking how to stop disease. And a message to say to everybody how to prevent disease by preventing and by local measures in terms. So they do not need to have another factor post any other procedure or non-necessary. Because local measures in dentistry play a very big part if you implement them the right way, the right time, and with the proper material, and to make sure that you have a good clean mouth and a good clot. Thank you.
Can I add one thing? Of course, I completely agree with Alison and Dr. Zikra. I think as this prevention is everything in order to prevent oral bleeding and manage oral bleeding. But again, in the top everything, I'd like to thank the WFH for put us together for a long time and spreading this news about oral prevention for a whole hemophilia community around the world. Because in the past, very, very past, I mean, I'm a dinosaur in this generation. We used to say for a patient who had bleeding in the mouth, just stopping brushing, stopping oral hygiene, because it's going to improve your bleeding. But now, since we have been working together, much more patients can have this advice that no, you need to keep brushing and clean your mouth, even if you have bleeding. So it's thank you, all the WFH, to put us together as an interdisciplinary team and spreading the news and spreading the information for whole patients around the world. We can see in our day clinic how it is happening, how bleeding has diminished, reducing over time. So again, thank you everybody. Thank you, WFH.
Well, we got a lot of good comments for all of you in our chat box, thanking you for your presentations. And so I'd also like to thank you. This has been a fun webinar. You all have done a great job in really communicating the answers to a lot of questions. And I think it was important to go back through some of these and reinforce the points that you made. So with that, I think that we should close the webinar. Thank you all for attending. Zikra, Elvira, Alison, thank you for all the work you've put into this. We very much appreciate it. And this will be up on the website, I believe, within the next few days. Louisa, Antonio?
Yes, in the next few days. We'll try to get it up as soon as possible.
Okay. All right, everyone. Have a good rest of your day. Thank you.
Thank you. Bye-bye.
Bye.